Hi, so thank you for that introduction, David. I hope this is not going to be a disappointment after that. So this is kind of the boring academic talk, I suppose, but I wanted to talk to you because we're having talks today from a lot of people that work in our organisation, and they're going to talk to you a bit more about the programmes that we run and various aspects of that. So I decided today I would talk about the journey to a public health approach, which is the journey that we've been on, I suppose, in Scotland for quite some years now. The thing about violence, though, is it was never a new problem for Scotland. So violence has been happening here for centuries, actually, but in the more recent past, we had the razor gangs of the 1920s and 30s, and we had the gangs of the 1970s, which are those handsome chaps there, second from the left. And we always had stuff going on, didn't we, in our more deprived communities, which are the wee boys on the right-hand side. And we even, for a little while, had Fred West resident in the local area. And I usually, when I do these talks, I say, homicide's a really reliable figure because the police find all the bodies. But, maybe not with him. He might have left somebody behind, so who knows? Anyway, thankfully, he moved off somewhere else before he became notorious. The thing about violence as well is it's not just a Scottish problem, it's a global health problem. So although Scotland was always in the papers for its high levels of violence, and we did have high levels of violence for a country of our size, we were always mentioned alongside other cities. Glasgow was mentioned alongside other cities that were much, much more violent. So I think looking around the world sometimes gives you a bit of reassurance that actually things here weren't quite as bad as we always made out. So if you look at Caracas, 24,000 murders in 1 year, that's a city. Guatemala City, 95.5 murders per week. I'm not quite sure how you can have 0.5 of a murder, but anyway, there we are. And San Salvador, 52.2 murders per 100,000 people in 2012. Those are astounding numbers. And when you look at places in Africa, you see similar sorts of things. And Glasgow was always up there. It was reported in the same article in The Guardian as all these cities. So 12 murders in 2011 in Glasgow, which, is 12 too many. I think we all accept that, which is 2 per 100,000 people. And that was when things were pretty bad here. From our own point of view, I worked for many years in maxillofacial surgery, and we were doing 4 trauma operations a day, generally every day of the week, back in 2007-8. And that might not seem like very much, but that's a whole day's operating. That's a whole day in theatre doing things that mean that you can't see the other people that have been referred to your service for routine stuff. People getting their operations cancelled because somebody had to have their mandible fixed. So that was actually a lot. It took up a lot of our time, and artists used to refer to Glasgow in terms that were to do with violence. So this is a popular artist, Glasgow. It's just a kiss away, referring to the Glasgow kiss, of course, which we did see too frequently. And the Glasgow smile was another one. So when did things start to change? So in 1996, and this is more globally really than just for Scotland, the World Health Assembly declared violence to be a public health issue. And that's really when things started to change, was when violence was brought into the sphere of health. And the World Health Assembly tasked the World Health Organization with doing something about it. So the World Health Organization does a lot of stuff around policy and prevention and suggesting things. So they were tasked with doing something about it. And then in 2004, the United Nations declared Scotland the most violent country in the developed world. And Glasgow was dubbed the murder capital of Europe, largely by the popular press, but they did base that on statistics. And any of you that are old enough will remember Taggart and his famous saying, "There's been a murder," which is, great said in a Glaswegian accent. So those things all happened. And the World Health Organization went away and did what they usually do, and they produced reports. So they produced the World Report on Violence and Health, and then followed that up with Preventing Violence, a guide to implementing their own recommendations. And they created the Violence Prevention Alliance as well, and we're members of that, along with the Violence Reduction Unit, who are also members of it. I think for a while they were the only police members of it. And that kind of created a movement, I suppose, those reports. It meant that violence was no longer just a criminal justice issue. It became a health issue. And that actually, it didn't take it out of the sphere of criminal justice. It will never come out of that sphere. But it opened up other options for prevention. It got more people involved in thinking about how they could prevent violence, and not just people within the criminal justice system. We need to be clear, though, there will always be a role for enforcement. There will always be a role for the legal system, because you can't just run about murdering people and think that there's not going to be any consequences. But I think bringing violence into the sphere of health opened the door for probably a more compassionate look at people, and a look at the reasons why people were getting involved in violence, because violence never comes through the door on its own. It always comes with something else. You know, there's very few people just born violent. And I'm saying that after that chap yesterday who murdered all those wee girls in down south. He does seem to be a bit of a tendency for violence. But most people are not like that. Most people are violent because there's something else going on in their life. This is a quote from the WHO. So despite the fact that violence has always been present, the world does not have to accept it as an inevitable part of the human condition. So violence is not inevitable. And this is the public health approach to violence prevention that the WHO put forward. So it's very similar to the public health approach to lots of other things. The public health approach is about how you approach disease effectively. So the public health approach to violence prevention has 4 parts. It's about gathering data, so you need to know what you're dealing with. That's really important. And there are lots of sources of data out there. You then need to identify your risk and protective factors, because if you don't identify those, you won't be able to develop interventions to tackle them. You then have to develop interventions and test them out on a small scale, and then finally scale them up to reach the maximum number of people as possible. So it's a bit like, and I'm not a big fan of this concept of violence being a disease, but it is a bit like a vaccination program. And I say that because you're all familiar with that now after COVID. So you kind of understand how you get to the point where you've got a vaccination that you deliver to the maximum number of people as possible. So that's the public health approach. It sits alongside this socio-ecological model, which recognises that violence has contributors at the individual, relationship, community and societal levels. So, for example, for individuals, if you have a substance abuse problem, that might contribute to you being violent on occasion. In terms of relationships, if you have friends who engage in violence, you might be more likely to get involved in violence because you're hanging about with people that do that. For communities, things like high crime levels and high unemployment levels can contribute to violence. And at a societal level, the more structural issues of inequality and poverty definitely contribute to violence. So this model shows you kind of where things happen, but it also points to places where prevention can be directed. So if you know these things, you can think about how can you prevent violence at these different levels. And most of us, I suppose, work at the first 3 levels. The societal stuff, the ending poverty, the reducing inequality, probably falls to government rather than to us, and God knows if that will ever be sorted, but there we are. So that's another model that sits alongside that. So back to Scotland. In 2005, the Violence Reduction Unit was set up, and I'm not going to talk an awful lot about that because Jimmy's here, and Jimmy's going to talk to you about that later. Jimmy's the head of the VRU just now. These 3 people were involved, and one of these people is quite often forgotten. So John Carnahan and Karen McCluskey will be familiar to lots of you as at the time, the director and deputy director of the unit. But everybody forgets about Chief Constable Willie Ray, who was the person in charge of Strathclyde Police at the time. And none of this would have happened had he not given permission for it to happen. He was obviously a man that didn't like the limelight, because I couldn't find a decent picture of him. There's only about 5 pictures of him on the internet, and most of them were out of focus unless you paid for them. So he obviously wasn't a mad fan of being seen in public, but that's him. I think he's retired now, so he's probably quite safe, isn't he? So what the VRU did was they adopted the public health approach, hook, line and sinker, and they looked for interventions that might work in Scotland, and they tried them out. But I think their biggest impact over that time really was the stimulation of discussion, their advocacy, calling others to action, and acting as a catalyst for things to happen. And people have actually looked into, there's a bunch at Glasgow University have looked into how the VRU worked, and that last paragraph is what they think that they achieved the most. They did do some very impactful programmes, so the Community Initiative to Reduce Violence did get a lot of young people out of the gang lifestyle, but that last paragraph is really where their main impact was. We followed on behind, so we started up Medics Against Violence in 2008, really got going in 2009 though. And then other programmes like No Knives, Better Lives, which is a Scottish Government-funded initiative, followed in 2009. But there are also many, many, many community and grassroots organisations that essentially work towards reducing violence, whether they think they're doing that or not. So we've got lots of people from Harbour here today who deal with addiction, but actually, indirectly, you're probably reducing violence. So you need to remember that whatever you think you're dealing with, you're probably doing other things as a side effect as well. So I want to show you, I'm going to apologise to the Assistant Chief Constable for having this. I shouldn't have this bit of film, but I've got it. Actually I thought you were leaving straight away. Anyway, so this wee bit of film, which shows a bit of disorder in the centre of Glasgow, and I have cut out the bad bits. It shows a bit of disorder in the centre of Glasgow, was something that was shown to me back in 2006, and it is what got me involved in this, because I worked in a hospital. I was used to dealing, I've seen everything gory that you can possibly imagine. None of that phases me at all. Usually when patients get to maxillofacial surgery, they've passed through the hands of the ambulance service and the emergency department. And usually by the time we got them, they calmed down a bit, they were a bit pissed off, or they were crying and wanting their mum. So we never really saw people in the state that they were in when they were in the street. But this film does show you what goes on in the street, and that is what got me involved in this. And I just hope I can get it to play. There we go. So this is the city centre of Glasgow, and there's lots of people because it's probably a Friday or Saturday night. And there's a lot of crowd of wee boys that have gone into town probably for a gang fight, because people used to just do recreational violence at the time. And they're all they've got their belts off, I think, and they're all ganging up on somebody. And they get them down on the ground, eventually, and just give them a good doing. And that's the real pack animal mentality, that, isn't it? It's horrible to see that. And this is another bunch, probably similar sort of area. And again, it's very hard to see who's with who in any of these things, or who the victim and the assailant is going to be at any given minute until you actually see it happen. But again, they get somebody down on the ground and they start getting stuck in. And this lot have got either a big kitchen knife or a machete. And that level of violence is just astounding. And you don't think when you see a patient in the hospital that that's what's happened to them. I know that maybe sounds a bit naive, but I never thought that. So that was what got me involved in this, because I was absolutely shocked at that level of violence. And the trouble with that is the first lot of getting your head kicked in leads to this kind of thing. So this is a much older man, obviously, but he's got a retrobulbar hemorrhage and he's blind in his eye, in the left eye. And that won't ever recover. So that's what getting kicked in the face can sometimes do to you. And this guy was hit across the face with a machete. And no disrespect to our emergency department colleagues, but they didn't notice that he had a comminuted mandible. So his mandible's broken underneath because they didn't take an x-ray. But that was nearly a full day in theatre putting him back together. And he was very, very lucky that he did get hit on the jaw, because if it had been a couple of inches lower, he probably would have lost his life. So that's the kind of thing that sort of violence leads to. And that's why I got involved in this. So we've got a health approach, and I'll go back to this concept, is violence a disease? So there are lots of people, mostly in America, who have touted this opinion that violence is like a communicable disease, that you can spread it from person to person. And Gary Slutkin is one of those, and he came up with this idea that violence spreads like a disease and that you could interrupt it. So he employed violence interrupters in Chicago, who are members of the community with lived experience, who go into the community and stop violence happening. So they get in the middle of things going on. It doesn't sound like a very safe thing to do, but it does seem to work. So it reduced violence by about 40% in Chicago at the time. And there's another chap called Andrew Papachristos who mapped a community in Boston and showed that the closer you were, not distance-wise, but relationship-wise, to somebody that had been shot, to a high-risk victim of gun crime, the more likely you yourself were to be shot. And the further away relationship-wise you moved from that person, the less likely you were to be shot. And that is regardless of things like deprivation, the social circles you kind of moved about in, and any other risk factors. So just being close to and knowing somebody who had been shot made you more likely to get shot. So those studies, I suppose, do think of violence kind of as a disease that can be transmitted from person to person. But I think we all know it's a bit more complicated than that because humans have choice as well. And choice is something that sometimes gets in the way of all these other things. So in terms of the public health approach, let's think about how you would do that. So, I shouldn't have this either, sorry, this map. That's all I've got, though. I'm just... I was just given it, so anyway, so in terms of understanding the problem, we need to think about getting data from somewhere, and there's lots of places you can get data. The police produce lots of data, so these are from, the top graph is from police recorded crime, so that's publicly available. And the other one is a gang map of the East End of Glasgow showing where all the gang territories were in 2003 and where all the incidents had happened. So all the green and red dots are where things had happened. All those kind of sources of data, health data, lots of other sources of data can help you build a picture of what's going on. So it's important to have data. The one thing I would say about data, though, is no data set is perfect because there's always things missing. So the most reliable police data is the homicide data because they do usually find all the bodies. The health data has holes in it because not everybody goes to hospital, not everybody's admitted to hospital, so there will always be people not included in the violence statistics who have been involved in violence. But I suppose what these things show you are top-line numbers and trends, so it's important just to caveat that. You need to also think about your protective and risk factors. So your protective factors for violence are education, employment, which I hope Father Greg will talk about because that's one of his homegirls there, and positive childhood experiences. So positive childhood experiences are all the things that happen to you in childhood that protect you later on. And we know that one of these things, having one single trusted adult in your life, is something that can protect you from lots of different things. So they're really important. People don't talk about them very much. And then there are factors strongly associated with violence. So being young and male is one, and these won't be news to you. Social deprivation, adverse childhood experiences and past trauma, being in a gang. It's not being in a gang so much that's the problem, it's what the gang does when you're in it that's the problem, because we're all in a gang of some sort, really. Care experience is another risk factor for violence and a whole load of other things, unfortunately. Exclusion from school, so if you are excluded from school, you're much more likely to be involved in violence and a whole range of other things. So it's really important to keep kids in school because it's a very big protective factor for them. Alcohol and drugs, I think we all understand, are risk factors for violence. And in Lanarkshire, at least, Buckfast has been responsible for a lot of the violence that happens in Lanarkshire. Other tonic wines are available. And head injury is another one that Michael might speak about because he's quite familiar with that. But if you have a head injury, you're more likely to get involved in violence in the future. So they're the risk and protective factors. When you're working with violence, you need to think about what level of prevention you're working at. So obviously we have primary prevention, trying to get to things before they happen. Secondary prevention, trying to intervene to prevent violence from happening again when it's already happened. And then tertiary prevention, where you're dealing with really ingrained problems. And some of our programs, the MAV Academy program, which is the schools program, works at the primary prevention level. On the Edge, which Sean and Callum and Robert will speak about, works really at the secondary prevention level, and the Navigator program really is working at the tertiary prevention level here. So thinking what we've done at Medics Against Violence in terms of programmes, we run lots of different programmes, and I'm not going to speak about any of them today. But what I will say is that all the programmes are evidence-based. So we've looked around for what might work and tried to adapt what might work to our situation. We can show that all of these programmes have impact in different ways. And it's absolutely, and I can't stress this enough if you're running programmes, it's absolutely vital to gather data. You need to have data because you can't prove anything if you don't have data. And the other thing about prevention is it's not a short-term fix. It's never going to be a short-term fix. And that's something that's sometimes a wee bit tricky to get across to the people that fund you, is that, it's not going to happen in a year. You're not going to have something to stand up at the government and talk about in a year's time. You're going to have to wait. So that's a tricky conversation sometimes. In terms of finding out what works, we do as much evaluation as we can, and Ryan's going to speak about some of that later, so I'm not going to speak about any of it. But we do as much evaluation as we can, and again, this is something that funding's difficult for evaluation. Nobody wants to fund evaluation. They want to fund your programme. They don't want to fund anything to figure out how it works. So we've done a lot of this with the goodwill of people who are doing it for nothing. And that shouldn't be the case either. Evaluation should be valued. But unfortunately, it's not. So that's just another plea to funders, I suppose. So once you've designed your interventions and you've found out what works, you can then scale them up. And this is we didn't actually send a bay out to the hospitals as the first navigator, but anyway, the point I'm trying to make here really is that we did, probably unwisely, an exponential scaling up of this programme. So we went from 2 to 4 to probably 8 and then 16 and so on. So if you scale things up too quickly, that can get tricky as well because you need to put effort into making the relationships with the people that you're working with. So you can't just parachute people in to somebody's hospital without making relationships with the people that are in the hospital, without making relationships with the people in the community who you're going to refer your patients on to. So I think we've learned lessons from that, and we probably wouldn't scale up as quickly the next time. So anyway, that's our Navigator programme, which is a great example of scaling up. We've also taken part in lots of partnership programmes. So we did a big training initiative with the fire service on domestic abuse. I did get into that fire engine. Let me tell you, that's not easy in a skirt. So I would have thought that through the next time. We also worked with various organisations to put together a domestic training initiative for vets. And that's my wee schnauzer in the news article, sadly no longer with us, but she was our pin-up dog for the programme. We worked with Police Scotland a couple of years running on their One Punch campaign, just putting forward that idea that one punch can change 2 lives, and so it can very quickly. And most recently, we've worked with the VRU and with No Knives, Better Lives on a campaign to try and target young people who are using social media to share images of fights. And that's Quit Fighting for Likes, so that's still live just now. So, thanks to the combined efforts of lots of people and organisations, violence did start to come down in Scotland using the public health approach, and it's remained at a much lower level for years now, although there are blips where things go up and down. We've got a much, much better understanding, I think, in Scotland of the impact of violence on communities and individuals and of the root causes of violence and the reasons why people get involved in violence, and that really does help you put prevention in place. We're much, much more trauma-informed than we used to be. There's been a big push in Scotland to be trauma-informed, and I think that really is starting to show through. I was at something the other day, it was at the Youth Violence Summit the other day, actually, and one of the young people were saying that the police weren't trauma-informed, and I did point out to the ministers afterwards that actually there are large swathes of the police who are very trauma-informed, and their domestic abuse arm is a really good example of that. We do understand that violence doesn't come by itself. It's often a symptom of something else, and that helps you find ways to prevent it. So just some graphs to show the outcomes, really, I suppose, in terms of where Scotland is now. The homicide rate, and these are stats from a Statista, which is not a police organisation. The homicide rate in the United Kingdom per region on the left there, so Scotland is 5th in the number of regions there. London's the most violent place in the UK at the minute. You can see that the rates of violence in all the UK countries have come down in the graph at the top right. And also in terms of Europe, we now sit, although they don't have Scotland on this graph because we're not in Europe anymore, but we now sit around about where the Scandinavian countries are. And aren't people always saying we should be more like Scandinavia? So there we are. We've managed to get more like Scandinavia. So just a couple of things about, I suppose, what we've learned. I suppose patience is one of them, that not expecting things to happen overnight, sticking with, being prepared for things to get worse before they get better, because when we started this, the violence stats got worse for a while before they got better. Working in partnerships, so important. You know, you need to put your ego to one side with all this kind of stuff and just work with other people. We value lived experience of all sorts, and that's both within our staff team, but also, you know, all of the medics that work with us, we value their lived experience too. I think it's important, and this is something that we've learned over the years, stick to your mission. Don't try and be something for somebody else. Stick to what you have decided that is the right thing to do. And that's another thing, you know, with funders, they will try and sort of squeeze you into the box that fits their mission, but you need to be really careful and stick to your own mission, because otherwise you'll probably fail. Don't be afraid to stop doing things if they're not working. So if something's not working, you should stop, you should reevaluate, you should think, well, how else can we do this? How else can we get best value out of it? Work in your sphere of influence. And by that, I'm not saying stay in your own lane, because if I stayed in my own lane, I wouldn't be doing any of this. But work where you have influence, where you know people, where you have friends. And we've largely stuck to the spheres of health and education because those are our experience. And that's probably worked out reasonably well for us. Use the best evidence. So look around, make sure that you are evidence-based. Look around for things that are working. Why are they working? Who's proved it? You know, data. Have to have data. You have to have evaluation. And the other thing is to be humble and recognise that no one person can do this. So anybody that stands up and starts to take the responsibility for any of this is on a hiding to nothing, because everybody has done their part in this. Everybody. However small a part, they've all done it. So this is not the efforts of any one person. And to me, this is what public health looks like. It's lots of people working together, lots of different projects, lots of different things going on. This is what public health is in real life. So that's all I want to say about that. But I just want to also mention our colleague Gary, who we lost this year. And you'll probably hear a little bit about Gary throughout the day today. But Gary was a lovely guy. He really was a lovely guy, and he was so funny. And we just miss him. So I just wanted to recognise him today. Thank you.
Any questions for Chris?
It's fine if you don't have any. Thomas.
Question. Showing the presentation, question in touch on the site of what they're trauma-informed, have more trauma-informed services, staff are more trauma-informed, environments are more trauma-informed. Do you feel it's just as important that the people that we support become more trauma-informed so they get a better understanding of how trauma affects them? Because I feel as if a lot of resources go into staff development in regards to trauma and trauma-informed environments, but the people who we support are kind of up with still don't have a proper understanding of how trauma affects them, so do you feel resources really go into informing people about how their trauma affects them?
Yeah, no, that's important. That's a good point, actually. You're right, because a lot of effort has been put into, and I know from the NHS point of view, we have lots of educational materials available on how to be trauma-informed, but yeah, we probably don't tell the patients. Yeah, so there's always a bit of a disconnect, though, isn't there? There always is, and it shouldn't be there.
Any other questions? Okay, well, thanks again, Christy.